algorithm of evaluation. So, as Sir said, ultrasound and then go to MRI. So, what is the correct way of algorithm in approaching the patient? Is there any specific variations that you like to, or is it, your practice?
So, so if you have a patient with fatty liver, right? So, first, I'm assuming the liver function tests are abnormal. If the ALT and AST, if it's a male, they are less than 30, I will not be doing anything to that patient. I won't do a FIB4, I'll not do anything to that patient, right? So, because their risk of fibrosis is negligible. Assuming you have fatty liver, you have abnormal LFTs, your ALT or AST is raised. That's reversible. Second is fibrosis, which is also reversible till it reaches a certain point. So fibrosis goes in 4 grades, F1 to F4. F4 is cirrhosis, as you all know. Cirrhosis has traditionally been considered irreversible. Now we are talking about reversing cirrhosis also, but I won't go there in this discussion. So F1, F2, F3, these 3 grades of fibrosis can be reversed. So as a clinician, my concern, so it starts off with inflammation, then it goes to fibrosis. So your inflammation is reflected by liver function tests. ALT, AST, 2 times normal, you know there's inflammation. Your liver function tests are not particularly good at telling you how much fibrosis there is. So now when it comes to assessing fibrosis, there are some blood test markers also. So the most common one is FIB4. Once you do your FIB4, you'll get a score. That score divides your patients into 3 categories. One is the low value where there is no fibrosis. So that is the safest group. Their risk of having liver events in the future is very small comparable to general population. Then the group that has a high FIB score above the threshold, which is 2.67 or something. So that group is at risk of getting progressive liver disease, cirrhosis, liver cancer. Then you have the intermediate group, the troublesome group. So if you have a high score, yes, you go get your fibroscan or go get your MR elastography. Obviously, the ultimate test, if you really want to know how much fibrosis there is in the liver, the ultimate test is, the gold standard is biopsy. But you have to think about it like this. So biopsy is like, just imagine you have an apple, right? You're putting a needle into the apple and taking a sample, and you're trying to test if the apple is rotten or not. It can be rotten in one part, not rotten in the other. So if you get the good part, you think this is good. So biopsy has a problem with a potential sampling error.
Correct.
It just depends on where you put your needle in that big liver.
We are catching fish in the sea.
Yeah, but that sampling error risk is, it's not very high. It's not like there's a 90% sampling error. You'll probably have not more than 5 to 10% risk of a sampling error. 90% of the times you're still going to get it right. MR elastography, essentially you're putting the patient into the scanner. Elastography of liver, I think as a concept, if you have a good liver, it is nice and soft like cheese. You handle cheese, everybody has handled cheese or paneer, it's soft like that, right? As it gets diseased, fibrosed, and once cirrhosis starts setting in, it becomes firm, right? Your cheese is now dried up and it's become firm. It's like that. So with elastography is nothing but squeezing the liver, just feeling it. Has it gone stiff or not? By that you're trying to say how much fibrosis there is. If it's really stiff, then it is, sometimes it can become hard. You palpate a hard liver, it's like that. So MR elastography, you're literally squeezing the liver trying to find out how stiff it is. So that is the non-invasive tool for finding out how much fibrosis there is. So to simplify the answer, if you have abnormal LFTs, that's the starting point. Do your FIB4. If it is low, on that algorithm. If it is in the intermediate range, you need to do some more tests and maybe other liver blood tests. There's something called the ELF panel, which is available, enhanced liver fibrosis panel, elastography, MR elastography, all these other things come in. Typically in medicine, whenever there is a scenario where you're unsure, right? don't try too hard to get a diagnosis at that point. Follow that patient. It's very simple. If they have MASH, lifestyle changes, lose weight. If they're drinking alcohol, stop drinking alcohol. There's now a condition called, so you have MASLD, which is metabolic liver disease. You have ALD, which is alcoholic liver disease. Unfortunately, with Indians, there's very, very few that have a pure MASLD. You have fatty liver and you're also drinking. So there's a condition called MET ALD, metabolic ALD. So it's a mixture of both. So if the patient is in the gray zone, you don't know how much fibrosis there is, put them through some lifestyle measures, bring them back in 6 months, because nothing is going to happen in 6 months. Your patient is not going to die of liver disease.
So that's great. So Sharath ultimately is saying that biopsy is the only gold standard with which we diagnose, and the truth comes from there.
I didn't say that. I said biopsy and